Good morning, everyone. My name is Siva Mulpuru. I'm a practicing electrophysiologist in Rochester, Minnesota. And it's a great pleasure to invite my colleague, Dr. Chris McLeod from Mayo Clinic in Jacksonville. Dr. McLeod is a practicing electrophysiologist. He is a professor of medicine and is also the director of the EP Fellowship at the Mayo Clinic in Jacksonville. His interests lie in translational electrophysiology, as well as treating arrhythmias in patients with adult congenital heart disease. He will start off the course with the first talk understanding basic arrythmogenesis. Thank you, Chris, for taking the time to do this.
Thanks, Siva. All right, so basic arrythmogenesis, really some key elements here that everyone should know, and I've tried to make this as clinically relevant as possible. There is some excellent heavy data on this, but I think it really makes sense as soon as you link it to patient care, ablation, devices. How does basic arrhythmia understanding help you? I don't have any disclosures, no off-label discussion. And then these are the main objectives. We're going to distinguish our mechanisms of arrhythmia. We're going to look at the triggered, automatic, reentrant arrhythmia mechanisms. Look at the EP characteristics of once that impulse has been formed, how does it propagate? Looking at cable theory, looking at anisotropy, and the basic mechanisms for each one of your clinical arrhythmias. Also looking at fibrillation, which obviously dominates a lot of our practice from an atrial and ventricular point of view. Starting on the left, abnormal impulse formation, triggered activity, automaticity. That would be some of the basic mechanisms we'll start off with. And then what happens, as I said, after that impulse is formed, and then what happens to that impulse in the heart under normal conditions and also diseased substrate. So we're going to start off with the basic action potential that you all know. With the resting potential, the myosite is at about negative 80 millivolts. This is maintained by your potassium channels chiefly, and then the initial upstroke, your phase 0, is driven by your sodium influx into the cells. This ITO, this transient outward current, governed predominantly by potassium, is going to initialize that first restitution, the first part of repolarization. So starting off then, repolarizing initially, moving into phase 2, and then phase 3, the bulk of your repolarization, driven predominantly by calcium and potassium, again, channels. We'll speak more in detail about that, but just showing you the synchrony and the flow, which is really an amazing orchestration of channel physiology for every single heartbeat and conducted impulse in the cell, and I guess in the muscle and in the nerve. For each cell that we have in the heart, that action potential looks slightly different. If we're starting off with the pacemaker cells in the sinus and the sinoatrial node, the action potential is very different. The resting membrane potential is at about minus 50 as opposed to minus 80. It's a slow change in the upstroke. It's continuous, calcium dependent. Moving to the atrial myocardium, a little bit deeper, resting membrane potential down to minus 70, driven then predominantly by sodium channels. The AV node, not as negative, at about minus 60. Slow activation through the AV node, calcium dependent predominantly. And then here in the Purkinje and the ventricular myocytes, you see that classic action potential with the phase 0, phase 1, 2, 3, and 4, where you're getting back down to a resting membrane potential of negative 80. I'm just taking one of those channels, which is just such an important one in electrophysiology, the sodium channel, and looking at its implication for disease and how it affects repolarization and depolarization. The sodium channel is a multimeric structure with 4 main domains, and you can see in this pictorial that there's a gate that's going to open and close to keep that channel in a functional state or in a closed state, with the influx of sodium being its primary goal. And affecting that channel here from a channelopathy point of view, if you had a SCN5A mutation, a sodium channel mutation, if you're unable to move sodium rapidly through that channel functionally, then you're going to slow that initial upstroke for the sinus node for atrial tissue. And so if that's sinus node, that's going to be sinus node dysfunction. And so some of these patients will end up with sinus node dysfunction based on a loss of function in that channel. The same for atrial fibrillation. If you've got slow conduction, and we're going to keep on coming back to this just for mechanisms of arrhythmia, slow conduction through any myocardium is essentially setting you up for re-entry, one of the precursors where you've got differential conduction through the heart, setting you up for fibrillation. So atrial fibrillation in a hereditary manner in some of those patients. Brugada syndrome also then affecting the sodium influx, and you can see there the influx has changed. You've affected then the transient outward channel as well by affecting sodium. So there we can see just reaching over into that from phase 0 into phase 1, leading to Brugada syndrome. And then for gain of function, that sodium channel can really also manifest as a long QT type 3. And sometimes you see that even in the same family. So similar channel, the same channel with similar mutations or mutations in that channel leading to different manifestations. We also know that SCN5A mutations can end up causing cardiomyopathies. That mechanism we don't fully understand. But you do also get these overlaps, where some of these patients will have a cardiomyopathy and a long QT or Brugada phenotype. So just using that as an example to illustrate how that channel can change. Mike Ackerman's going to speak a lot more about that, but just starting off with the sodium channel then as your initiation of your impulse for electrical conduction through the myocardium. So once that impulse has been initiated, how does that get through the cell? Chiefly, this is at the gap junctions. So at the longitudinal ends of your cardiac myocytes, we have these enriched regions of gap junctions which allow for rapid facilitation and change of that electrical conduction. And so it's not happening or it's not occurring because on the transverse aspects of these cells, it's only really because the gap junctions are enriched at the end of cells. That does change with disease, and we'll go over that. But it's the gap junctions that are going to facilitate this impulse conduction from cell to cell after sodium initiation. And so just as a model, as an explanation for how electrical impulses or electricity will move through a cell, this has been used for many years, is cable theory. And that would be the same for your axons through the body, in the brain, and in the heart. Conduction of electricity through the heart muscle is going to be determined by a few fundamental elements. It's the primary axial resistance, which is being encompassed in this equation, and it regulates the flow and thereby the velocity of how quickly electricity can transfer down a myocyte, through a syncytium of cells. There is going to be an extracellular resistance, the resistance outside the cell, resistance inside the cell, and it's these gap junctions which are going to facilitate that inside resistance, the internal resistance or the intracellular resistance. That then will dictate how quickly electricity can get through from A to B. So why is that cable theory relevant? We'll bring up a few examples. I'm going to start with this from an anatomical point of view. You can see here that the ventricular myocardium, if you dissect and remove a lot of the connective tissue, is not just a chunk of muscle. It really is folded in a way that there really are essentially cables or fiber bundles, where those fiber bundles their orientation is crucial for early activation from A to B, or rapid activation from A to B, because it's facilitated by these gap junctions, which occur rarely only in the longitudinal aspects of those cells. You can also see from this MRI reconstruction, even though we have fiber orientation on one particular level, that's not the same throughout the muscle. You've got endocardial cells, midmyocardial and epicardial cells, and the fiber orientation can be very different. So being aware of that is very useful for pacing. It's very useful for ablation. The fiber orientation, if you're able to leverage that, you can use that for resynchronization, or it can be your enemy with resynchronization. So let's look at this anatomical view on the left for a second. If we're placing an outflow tract lead, maybe we couldn't get in a conduction system region lead because of scar down here, and you place a lead up here, you can very rapidly activate the lateral wall of the heart, because you are going to be facilitated with your conduction, conducting down those fibers, along the fibers in a longitudinal manner, as opposed to a transverse manner where conduction is going to be very slow. So this is an ECG which we pulled out just a few weeks ago. This is a patient who has a lead that is penetrating the left bundle area. You can see in V1 a nice right bundle pattern, so we're capturing the left bundle. But if you zoom in and you look at some of the other leads, you're capturing the left bundle, but you're negative in lead 1. How does that happen? You're facilitating that conduction by getting to that lateral wall very early. You can only be negative in lead 1 if you're getting there first before anywhere else. Even though there is a little bit of fragmentation and maybe a little bit of an isoelectric segment initially, the bulk of the vector for pacing at the left bundle is moving away from the left shoulder, which is exactly what you want from resynchronization of the heart. One of the key features we look for when you're placing a lead in the coronary sinus is exactly that signature. How did that happen? Longitudinal function, but also the fascicular system, which running in a longitudinal area is going to get to that lateral wall very quickly, and we'll review that. You can get there to that lateral wall very easily also by getting that lead in a particular region in the right ventricular outflow tract. So here, experimentally with catheters, pacing in the right ventricular apex, we can see lead 1 is positive, getting slow conduction and ultimately getting to the left ventricular free wall. Right ventricular septum, also delay getting to the free wall. But if you go out into the outflow tract and you leverage that anatomy and you leverage that fiber orientation where you've got rapid, facilitated, longitudinal conduction, you very often see this. And you'll often see this also with your outflow tract PVCs. They'll be negative in lead 1 because they're activating. They can be right ventricular outflow tract, but they're bringing in that lateral wall very early. Another important consideration is when we think about the atrial anatomy and the fiber orientation. So I'm sure most of you know when you've got your catheters in the right atrium and it's up against the crista, you're going to see two signals, a split signal at the back of the right atrium, which you're going to quite rightly assume that's the crista. There probably isn't block in the crista as a whole. It's not in all patients a band of fibrous muscle. You can conduct very quickly down the crista in a longitudinal way, but very slowly in a transverse way. So just bear that in mind. These fibers can be your fastest conducting regions and your slowest conducting. So slowest transverse, very rapid longitudinal. And so ablation in that area or arrhythmias in that area, if you've got scars related to atriotomy sites, really can be challenging when you've got slow conduction through some of these areas that facilitate re-entry. The same thing here, very much a difficult arrhythmia to ablate. If you're looking at Bachmann's bundle, here we have the left atrial appendage. We're looking down on the roof of the heart, roof of the left atrium and right atrium over here. You've got the fibers from Bachmann's bundle running across. So very rapid conduction getting from right atrium to left atrium. Another example of that anatomically, right atrial appendage over here, left atrial appendage over there. And here you have these fibers or cables that are running longitudinally across the roof of the heart. What if you assume this is a focal atrial tachycardia and you ablate the earliest site here on the right atrial side? You then have very slow conduction, no longer rapid conduction along the roof, very slow conduction across that Bachmann's bundle. So you can set yourself up for a really recalcitrant atrial flutter by mistaking the mechanism of tachycardia, but also not taking into account that you can get very slow conduction if that arrhythmia is now leveraging. It can't go longitudinal, but it can go transverse. You've set this up for a recalcitrant atrial tachycardia that can be biatrial, very difficult to ablate because this Bachmann's bundle is now sitting on the epicardial surface. So some important things to consider also on ablation of the posterior wall and on the roof, where you've got those different layers of endocardial and epicardial bundles running in different directions. As we spoke of with that pacing ECG, very rapid facilitated conduction in the ventricles through the Purkinje fibers, around 8 to 10 times faster than what we see in the myocardium of the atrium, even twice as fast as the bundle of His in the ventricular fascicles. So very rapid conduction, facilitated conduction. This is what we want to use when we want coordinated synchronous activation of the ventricle. So how is that changed? You can think of how do we impact the resistance of that cable? We can see all the illustrations earlier is where resistance is inside the cell, outside the cell, and the interstitium is going to change based on certain pathological syndromes. And so ischemic cardiomyopathy, we've got infiltration here with scar. You can then see how that's going to change the velocity, the conduction velocity through myocardium is going to slow it down. Even worse so in some of these dilated cardiomyopathies where you've really got delayed conduction because of infiltration of fat and fibrosis that we pick up as pathological elements in both of those cardiomyopathies. Slow conduction setting you up for re-entry. We also see conduction velocity then start to change with age. In all animals, as the heart ages, we see that conduction slows. And there's resistance that's changing because of fibrosis between the cells. But also we see that as the heart and all organs, as they get older, we can get some anisotropy. So we'll discuss that in more detail, but the fiber orientation starts to change. And if the fiber orientation is changing, we also see increased resistance in the system. We see that it facilitates slower conduction in certain areas. Aging, normal aging processes also affects the enrichment of certain channels, the sodium channel and potassium channel, which is going to affect the gradients across those membranes, make depolarization more difficult in some regions. If depolarization is slower, there's going to be slower conduction, also setting patients up for re-entry like atrial arrhythmias. Heart failure, more fibrosis in the cell, more resistance, slower conduction. But we also see a major decrease in heart failure in patients with, we see a major decrease in connexin 43. So that's part of your gap junction machinery that conducts and facilitates conduction, rarely goes down in patients with heart failure. So you can see manifest then in your QRS duration on the right panel there. As that QRS duration goes up, so does mortality and so does incidence of heart failure. The wider the QRS, the slower the conduction and more likely re-entry. The same thing actually holds true for left bundle branch block, narrow left bundle branch block versus a wide left bundle branch block. The wide left bundle branch block associated with a higher mortality. Much more important to resynchronize those patients. What about ischemia? This also acutely will change that tissue impedance and the resistance. Goes up immediately as you make that artery ischemic or that tissue ischemic. If you prolong the ischemia, you're going to change that potassium cell. The sodium potassium ATPase needs ATP. It's ischemic, it can't use it. The potassium extracellularly then rises, and it's going to change that resting membrane potential. It's going to make it more difficult for that cell to depolarize. So slower conduction in ischemic tissue. Chronic ischemia, also we see, like in heart failure, connexin 43 and gap junction enrichment goes down. What's interesting in hypertrophy, pathological hypertrophy, aortic stenosis, hypertrophic cardiomyopathy, is we see these gap junctions start to relocate to the transverse aspects of the cells. So think of the longitudinal enrichment being there to facilitate rapid conduction, and as soon as you start moving those gap junctions to the lateral aspects, you can facilitate discoordinate activation of those cells and maybe even set those areas of muscle up for fibrillation. No longer is it a clear conduction with rapid velocity. You've got conduction going in multiple different ways, facilitated by this lateralization of gap junctions in pathology. Volume overload, if you stretch the myocytes, this activates certain channels, and we'll look at some of those channels a little bit later. But those channels then change the resting membrane potential, essentially, changes the capacitance of the cells. And you can see here in this diagram, just experimentally, loading the right ventricle, and you can see the conduction velocity dropping very quickly, offloading the right ventricle, conduction velocity changing, and this is because of the resistance changing in the system as part of this cable theory. So you've initiated the impulse. We've looked then at how it's going to transmit through the cell, but what about the size of that impulse? So this is the concept of source sink that you have probably heard of. The size of the source, the size of that initial impulse, really does have implications for downstream activation of those cells. So the larger the source is, the more likely it is to effectively depolarize downstream, which we're calling the sink. So the larger the source, the more current it'll generate and more able to depolarize downstream. So small little pebble in a big lake isn't going to have much effect, but a big rock in a small pond is really going to impact conduction in a major way. It's going to cause ripples, it's going to affect that. So a smaller sink, small bit of myocardium really doesn't need very much source to get it to that depolarization threshold. What are other things that are going to affect that flow of, if you drop a pebble in the pond or in water, what is going to affect that flow? It's going to be resistance and capacitance. What are the things that affect resistance and capacitance? It's fibrosis, it's gap junctions, it's the ease in which that current is going to make its way through the tissues. So lower resistance, less waves in the system, better flow, more effective depolarization of that sink. And then getting to what happens then with fiber orientation changes, as you saw from those anatomical specimens, that not all the fibers are aligned, especially around the AV node, especially around the atrioventricular valves. There is going to be orientation of fiber that changes, even from the endocardium to the mid-myocardium and the epicardium. So as electricity is conducting down a cable, and I like the water analogy, if it is then coming to a smaller sink, that anisotropy, as it moves from a larger source to a smaller sink is going to change the velocity, the conduction velocity of that electrical impulse. And drawn in this pictorial, you'll see as the conduction velocity is impacted by the change in source to sink and fiber orientation, the convex aspect, so as you're moving into a larger sink, that slows down conduction. If you are funneling into a small sink, this sort of concave conceptual model, you're going to speed up conduction. It's like holding your finger over a hose. Small, you narrow up that hole on the tip of the hose, and you're going to increase velocity. You make it a wide hose opening, slow velocity. Why is that clinically relevant? Really nice summary paper, now around 30 years old, from Mark Josephson at the time and his group. AVNRT. What are the causes for AVNRT? There are lots of postulates. Maybe there are different cells. Maybe there really are some vestigial pathways. But one of the more common explanations that he put forward in the 90s is this anisotropy around the junction, around the AV node. There's lots of anisotropy from the coronary sinus to the septum. That is going to change the velocity of tissue. And that's all that you need really for AV node reentry. We know we've got some portion of delay within some part of the AV node, and we know we've got some slow conduction somewhere and some fast conduction somewhere else. So you need both of those, or just two areas of slow conduction really, for AV nodal reentry. Postulating, even back then 30 years ago, a mechanism for AVNRT which still holds true. Anisotropy around the AV node. Same leader in electrophysiology. He published then 20 years later on the same conceptual theory then behind some of the changes that we're seeing with high density mapping in ventricular tachycardia. Why are we seeing crowding of isochromes at some portions of these isthmuses? As the ventricular tachycardia is moving into the isthmus, it's going to accelerate. As it's moving out of the isthmus, it's going to slow down. And as it's slowing down, you've got some slow conduction, which is providing that opportunity for repolarization to complete and for reentry to occur. So reentry needing that gap in timing, that excitatory gap, allowing for repolarization and then another opportunity for depolarization. So isthmuses are a perfect opportunity to leverage this anisotropy source to sink mismatch as conduction velocity will be affected. Also a few things just to bear in mind, some peculiarities that you'll see, but also basic fundamentals of conduction and peeling back refractoriness, a nice phenomenon that you'll see fairly commonly in the lab. Here we can see ECGs and intracardiacs of a patient with left bundle branch block. Wide QRS and then PVC comes in. That then allows time for repolarization. Also, as you know, for almost all myocardium except AV nodal tissue, bringing in an early beat really resets the repolarization dynamics. Repolarization is going to be faster at faster heart rates. So timing changes. You bring in an early beat, you reset, you give time for repolarization to occur, but you've also reset the repolarization clock for the next beat. So the PVC comes in, it changes repolarization, it peels back what we think of as the refractory period, and the next beat, same heart rate, is now conducting without a bundle branch block. A really nice example of this happening in the atrium that Amit Noharia and his colleagues published on last year. Very nice case report in Circ EP. Here you can see the intracardiacs for a patient with a long AH. So potentially using a slower area of conduction from that potential slow pathway area, getting from the atrium to the his, and a PVC comes and conceals into that area and changes the refractoriness of that tissue, and from then on a shorter AH interval. Widensky phenomenon is something also just to be aware of. I think we see this more often than we think, and it's just not recognized. I think we see it more commonly in patients with heart block, where you look at the ECG and it's not really complete block, meaning it's not regular, meaning maybe some of those atrial impulses are conducting. And probably what's happening is this phenomenon of partial depolarization. So there is disease. It's not able to depolarize that area of myocardium or that cell or the AV node completely, but it does change the threshold. It's changing that resting membrane potential, so it facilitates the next beat being able to conduct. So changing that membrane potential, facilitating next beat conduction. So here's an example of some subtle changes in a patient with what we call high-grade AV block, and really there's probably some Wadensky phenomenon where it's changing and facilitating conduction. So let's look at those mechanisms now. We've looked at conduction through the heart and some phenomena that you'll see, but we'll start off with automaticity. Reduced automaticity, there are some unusual primary forms of this. These are channelopathies, HCN4 mutations, where we're going to affect that inward current, and we're going to change the initiation of the impulse. Familial and quite rare. The more common that you're going to see, other than that familial aspect of sick sinus syndrome, is going to be secondary. So changing the regions where initiation of impulse is occurring through infiltration, and usually with fibrosis, scarring, and as you can see on the right there, a long list of causes for this. But anywhere, and then going back to that cable theory, is anytime you're changing the intracellular or extracellular resistance with fibrosis or infiltration, you're going to affect conduction velocity. You can also then affect also depolarization characteristics. So what about enhanced automaticity? And one of the more common ones that we see is that junctional tachycardia, early post-operatively, after cardiac surgery, comes and goes. Very often it doesn't cause, or most often is not really a pathological element, and very difficult really to put our finger on exactly what happens in that phase, but enhanced automaticity from the junction. Another is we see this as a trigger for potentially some re-entry within the Purkinje system. Mel Scheinman has done a very nice review, which I'm referring you to there. So automaticity in the His-Purkinje system leading to some re-entry. And then automaticity as it relates to parasystole. So parasystole being a region of myocardium, cell or cells that are protected. So there's an area of automaticity that is protected from depolarization. So there's entrance block into that area. Modulated parasystole is that there is partial entrance block. So every now and then something is going to be able to get in. Ultimately, though, you can see exit. This can happen in the atrium. This is seen in ECGs as far back as ECGs have been looked at carefully, even those early Shamroth books and papers, but also commonly in the fascicular system. Parasystole occurring there, and you see those PVCs from the fascicular system just walking through. They're not able to be depolarized. They're happening in a parasystolic manner in the fascicular system, giving you PVCs and sometimes even slow VT. So triggered activity then, early and late after depolarizations. Let's start off with the early depolarizations, defined as happening within phase 2 or phase 3 of your action potential. Usually this is tissue that's been exposed to some kind of injury. The electrolytes could be driving it, channelopathies, hypoxia, drugs. Also hypertrophy predisposes to, and heart failures, to this phase 2, phase 3 triggered re-entry. So as before completion of the action potential, we're getting spikes of depolarization that are triggering these ectopic beats. The early depolarizations are really something that you see predominantly at the slow heart rates. And so that's why that is really a very dangerous combination, where you have someone with a long QT or a channelopathy that's leading to that, and they are bradycardic. A very dangerous combination. You're going to prolong repolarization, with those slow heart rates, and you're going to make it more likely for these early after depolarizations to occur. So the delayed after depolarizations, those are the ones that are happening after completion of repolarization. So now we're in phase 4 again. They're triggered activity that are predominantly driven by calcium. So we think of those two main ones that are most commonly cited in papers and textbooks. So digoxin toxicity, which we hardly ever see anymore. So those are the late after depolarization. There's calcium overload in the cells from digoxin. We've got CPVT driving this as well. And also your outflow tract tachycardias and some of the atrial tachycardias are triggered calcium driven. So you can see some bidirectional VT here with CPVT. And so how do you load the cells with calcium? How do you make this more likely to happen with CPVT, with dig toxicity, with outflow tract VT? Is you stimulate the cells to increase their heart rate. So faster heart rate will bring on more likely more outflow tract PVCs, more likely outflow tract VT if you want to bring it on in the lab. Start isoproterenol, increase. And here's a nice diagram of that. Bruce Lerman has done a lot of work on outflow tract VT, and it's a very nice summary from this year, which I'm just putting in for you to refer to. That clinical phenotype of outflow tract tachycardias and CPVT, calcium loading of the cells, calcium overload, leading to those sparks of tissue that are going to create PVCs and ectopic beats after completion of repolarization, whereas slower heart rates for the long QT and your torsades. Moving then from the triggered arrhythmias to reentrant arrhythmias. I just love this explanation or this early work on reentry done around the turn of the century, looking at jellyfish. That was the model to really understand electrophysiology back then and electrophysiological reentry. You can think of jellyfish as a floating syncytium of heart muscle out there in the oceans, but essentially illustrating that reentry in that jellyfish, where you have a circular tissue that conducts electricity, you need an area of unidirectional block, functional unidirectional block, and an excitatory wave that is going to proceed along that pathway and return to its origin. And if you interrupt that at any point, you've broken that circus movement reentry. So what else do you need for that? You need a boundary. So that's easy with the jellyfish. There's nothing in the middle, and that's why they used it as a principal experimental organism. A boundary, and you need slow conduction. So when that wave of electricity reaches, or your electrical impulse reaches that tissue again, gets back to its origin, that area has completed its repolarization, can then be depolarized. So all of that fibrosis, all of those gap junctions really are key drivers to influence conduction velocity, which is influencing when repolarization is happening. Because the heart is not a 2D or 1D structure, this is really happening in a three-dimensional manner. So think of these spiral waves as being not just uniform in one layer of cells, but really acting the heart like a scroll or a spiral, much more dense, penetrating deeper into the tissue. But is there something that it's centering around reentry when it gets to fibrillation? And we'll discuss that. But basic reentry, a boundary, along with slow conduction, allowing for repolarization. How can you also modulate that? We alluded to this earlier with these stretch receptors. They are all over the cells, lots of different channels that are going to affect that resting membrane potential, stretch-activated ion channels that is going to ultimately affect conduction just through feedback that's consistently happening. One more phase of reentry just to touch base on before we discuss fibrillation is phase 2 reentry. Typically, this is in the myocardial areas where you have a change in the repolarization characteristics. So think classically here of the outflow tract of Brugada syndrome, where you've got endocardial, mid-myocardial cells, epicardial cells. Conduction velocity is different, but so is repolarization. So you're having re-entry occurring in phase 2 of that action potential because the repolarization is happening at a different timing. So phase 2 re-entry, multiple different layers of cells or diseased cells where repolarization is happening at different times. We call that spatial dispersion of repolarization. Looking then at this in more of a 3D-dimensional space then, setting up in that spiral or scroll and not just on that one cell at a time concept. This is going through from epicardium to mid-myocardium and endocardium. If it's all happening at a different repolarization time, phase 2 is at a different time, you've set up this dispersion of repolarization, phase 2 reentry in that region. The same thing here, looking at the distinct changes, just being aware that that epicardial area has the that the myocardium has got these epicardial cells, your M cells, your endocardial cells, and variable expressions of channels throughout that. And that's why certain arrhythmias like Brugada focusing in on certain regions of the myocardium as triggers for the arrhythmias. Phase 4 block, also as part of a bradyarrhythmia mechanism, think of disease within the fascicular system. So His-Purkinje system, it's leaky, the basement membrane resting potential has changed. It's more difficult for depolarization to occur. So bradycardic dependent, pause dependent block. If there is block, the leaky membrane makes it less likely for depolarization to occur. So phase 4 block in that restitution phase. And then our last slide then, just to wrap up on fibrillation, and is a mechanism of ventricular fibrillation, but also atrial fibrillation. A really fantastic review I would refer everyone to that Peng-Shen Chen did with colleagues around 20 years ago now. It's entitled A Tale of Two Fibrillations, and there really are two predominant conceptual hypotheses for fibrillation in the ventricle, but also in the atrium. What about these multiple wavelets? So if you have conduction that's proceeding through in a linear fashion, you can't have fibrillation. Well, what if the gap junctions are on the side? What if you've got fibrosis? What if you've got a pap muscle, a valve, something to disrupt conduction through that myocardium? They break up into these multiple wavelets and they feed off each other in a multiple wavelet hypothesis. But is there a functional driver for that? Is there a rotor? So the proposal for the ventricles, for ventricular fibrillation, is this is the Purkinje system. This is the fascicles. That's why targeting them with ablation is going to be more and more used. As you know, lots published on that already, but those are occurring at different rates, different cycle lengths to some of the other fibrillatory waves through the heart. The epicardium is also interestingly happening at a different rate. So those two hypotheses to be aware of for fibrillation. So just to summarize there with abnormal impulse formation, we spoke about the types of block that would come up. Triggered activity, early after depolarizations, delayed, automaticity, enhanced, and parasystole. And then re-entry, regular circus movement where you've got these anatomical obstacles like scars, valves, you need slow conduction. And then phase 2 re-entry where you've got this dispersion of repolarization. Thanks very much for everyone's attention. And Siva's going to come up and we'll address some questions and discuss.
Thank you, Chris. That was a fantastic overview of the basic mechanisms of arrhythmias. We do have a lot of overlap between some of the supplemental talks, like the pharmacokinetics of antiarrhythmic drugs, action potential by my colleague, Dr. Ackerman. Chris, so will the questions on the ABIM will be testing just these concepts, or will they be interwoven into a clinical presentation? How do you envision that being tested on the boards?
Yeah, I think definitely both. I think that some of those basic slides there, understanding channel physiology, which channels are activated during which phase of the action potential, is so easy to write board questions. And as someone who writes these questions, it's tough to get a good board question, but those are so easily testable. You're never going to really need some of that in the EP lab. But that's why I did try to make it a little bit more clinically relevant as to conduction velocity, and its relevance for re-entry and arrhythmias. And so you definitely will see both. But I do think those basic elements are very easy to test, and also which arrhythmias have which mechanism. So is it early or delayed after depolarizations for long QT or outflow tract VT? Seeing an ECG or telemetry strip of phase 4 block, Brugada with phase 2 reentry. I think there is going to be some clinical overlap there. I think hopefully it moves more and more like that. More relevant, the better.
Yep. There's one question from the audience. So in your slide, you showed about the action potential how that sodium channel is affected. It also affects the potassium channel in phase 1. Is that the mechanism with quinidine, the drug?
So quinidine does a lot in the heart. I think of it not just as a class 1A, but I also think it as a class 3, because it is going to affect your potassium channels and your sodium channels. And if you think of it as just sort of a weak amiodarone, it can affect everything. It's not going to affect your beta cells, but it is going to affect your sodium and your potassium. And that's why you can get a lot of ventricular arrhythmias at high doses of quinidine. And that's not through the sodium channel mechanism, that's through the potassium channel mechanism. So that is yes, it will affect both. And there's a great talk on that by Peter Noseworthy. It's in the supplementals. He goes through all of the antiarrhythmic drugs, looking at the action potential, and it's a fantastic way to just review for the boards. That definitely is a very nice, easy, testable concept. Quinidine, I've used more and more recently, especially in malignant mitral valve disease and mitral annular disjunction and PVCs from that area. I found it very useful.
Yeah, as we find new clinical syndromes, old drugs become new again. Mm-hmm. Yeah. So the other interesting slide they have shown is that peeling back of refractoriness. How putting in that PVC, bringing it an earlier beat changes repolarization. Is it predominantly just the repolarization, or will that transeptal conduction would be also affected, causing that bundle branch block in that slide?
Yeah, so it's the transeptal, the conduction through the septum. So one of your bundles is blocked, the other bundle is being activated, and then it obviously has to get through the septum. And then that is maintaining that refractoriness in that other bundle. But if you get in early, it then allows time for that recovery to occur. But it's what maintains your bundle branch block. Conduction, concealing across the septum into that other bundle maintains it.
I think that's an easy testable question on the boards, showing that tracing and asking the basic understanding why this is happening and what causes that normalization of the QRS. And your slide illustrated it so beautifully.
Yeah, so clinically you see that more often than not, and you'll see that as a very useful clue in some of your telemetry strips when you've seen a wide complex rhythm and then it changes into a narrow complex rhythm and there's a beat in between, alluding or giving insight into it's not a wide complex ventricular arrhythmia, that it really was a funny looking bundle branch block.